We are live now, sir.
Okay. Good evening, friends. Today we are going to discuss galactose metabolism, fructose metabolism, and sorbitol pathway. We start with galactose metabolism. Before that, you must know what are the source of galactose. Sources of galactose, the main source is milk. Breast milk is having lactose. Lactose is made up of glucose plus galactose. What is the site of galactose metabolism? Main site is liver. Liver is the main organ of metabolism. Most of the pathway occur in liver. If you want to simplify galactose metabolism, you must understand the structure of galactose. Galactose and glucose are epimer. We know C6H12O6, molecular formula of glucose and galactose. So this is glucose. This is galactose. So only difference between glucose and galactose is OH orientation at C4. At carbon number 4, OH is on right side. This is glucose. At carbon number 4, OH is on left side. This is galactose. So they are epimer at carbon number 4. Epimer. This question is asked directly, indirectly, and you must mention in the enzyme also. I am going to tell you. Epimer at C4. So if I am having one galactose molecule, suppose this pen is galactose. In this galactose at carbon number 4, OH is on left side. If I hold this OH and rotate this OH from left to right, it will be converted to glucose. So galactose metabolism is nothing but conversion of galactose to glucose. So you can easily remember galactose metabolism is conversion of galactose to glucose. Okay. How it is possible? If you hold this OH and rotate this, the complete molecule may rotate. That's why what we do, first of all, we will activate this galactose. We will activate this galactose by galactokinase. Galactokinase. You all know all kinases are transferase. All kinase require magnesium as cofactor. Whenever kinase is used, either ATP is used or produced. In this, ATP is used. ATP is used to convert ADP. And galactose 1 phosphate is produced. So we activated this galactose, some energy will be required, and we will attach this galactose in UDP. You know that whenever carbohydrate want to do a new work, it attach itself to UDP. In glycogen synthesis, we have seen that UDP glucose is formed. UDP glucose give glucose to pre-existing glycogen. So in the same way, this galactose 1 phosphate will attach to UDP and UDP galactose will be formed. I am skipping few steps. Don't worry. I am simplifying it for the time being. UDP galactose. Now this is UDP galactose. Now I hold this OH and rotate this OH from left to right. Now it would become UDP glucose. UDP glucose and glucose. So this is galactose metabolism. Got the point? Animation if you want to see. Yes. This is structure of galactose. C6H12O6 at carbon number 4, OH is on left side. Now, if I hold the OH of C4 and rotate it on right, it would become glucose. But before that, we must add it to UDP so that you can rotate it. So galactose 1 phosphate react with UDP glucose and galactose is transferred to UDP and this phosphate group is transferred to glucose. So glucose becomes glucose 1 phosphate and galactose 1 phosphate becomes UDP galactose. So this is galactose 1 phosphate uridyl transferase. The name of enzyme is galactose 1 phosphate uridyl transferase. It will transfer galactose from galactose 1 phosphate to UDP. Very important. Now, next enzyme is UDP galactose 4 epimerase. Means at carbon number 4, we will rotate. Sometimes MCQs are asked that which of the following is not involved in galactose metabolism. Option A, galactokinase. Yes, it is involved. Option B, galactose 1 phosphate uridyl transferase. Yes, it is involved. Option C, UDP galactose 4 epimerase. Yes, it is involved. Option D, UDP galactose 2 epimerase. Yes, it is 4 epimerase because we know galactose is epimer of glucose at C4. So this is not the enzyme involved. Now, clinical aspect is more important. If galactose metabolism is asked, you must write galactosemia. If galactokinase is deficient, if this enzyme is deficient, then it is called minor type of galactosemia. Minor type of galactosemia. Galactokinase is not working, so this galactose will not be metabolized. This galactose will accumulate in blood. When this galactose will accumulate in blood, yes, it will be freely filtered via glomeruli. It will be freely filtered. This is galactose freely filtered. But you know, renal threshold for glucose and galactose is high, is very high. At the same point, I will write renal threshold for fructose is low. Fructose renal threshold is low. So you will remember this point. So this galactose will be freely filtered and will be reabsorbed. In spite of reabsorption, some amount of galactose will come in urine and will give Benedict test positive. Benedict test positive. You all know that galactose, glucose, fructose, all monosaccharides are reducing sugar. They give Benedict test positive. One point. It is lab diagnosis about minor type of galactosemia. In this patient, this extra galactose which is present in blood will be converted to galactitol by enzyme aldose reductase. Aldose reductase. And you know, whenever we require reduction, we use NADPH. Okay, leave this. This galactose is converted to galactitol, and this galactitol accumulate in lens to produce oil drop cataract. Oil drop cataract. Another name of galactitol is dulcitol. Another name is dulcitol. Mnemonic. Girl. Usually in winters, you have seen that girls are using moisturizing cream, and one girl says to another in advertisement, your skin is so dull. Are you using cream of oil? So if you are using oily cream, your skin will be dull, the girl says. So galactitol, dulcitol, oil drop cataract, little bit relation would be there. So minor type of galactosemia, only and only symptom would be oil drop cataract. Only and only cataract would be there, and in lab diagnosis, Benedict test would be positive. Now, if galactose 1 phosphate uridyl transferase, this enzyme is defective, then galactose 1 phosphate will not be metabolized. This will accumulate. Galactose 1 phosphate will sequester all the phosphate, inorganic phosphate, means in cell, phosphate would not be available to do any other work. Important point. Galactose 1 phosphate will accumulate. All phosphate used. No phosphate in cell. Inorganic phosphate in cell. So in brain, Phosphate is not there, decrease ATP will lead to mental retardation, or new name is intellectual disability. Intellectual disability. One question. If phosphate is not there, then glycogen phosphorylase will not be activated. You know, in liver, glycogen is there. In between meals, blood glucose is maintained by liver glycogen. Glycogen is broken down to glucose, and the rate limiting enzyme is glycogen phosphorylase. And this glucose come out of the liver to blood. This glucose come out of the liver to blood. Okay. In normal person or normal child, this would be source of glucose in between feeding. In between feeding, blood glucose is maintained by liver glycogen. But in this patient of galactose 1 phosphate uridyl transferase deficiency, this glycogen will not be broken down because glycogen phosphorylase will not have phosphate. You know, glycogen phosphorylase. This is glycogen phosphorylase. I remember glycogen phosphorylase as Thanos. And Thanos require phosphate to be activated. It requires 6 stones. So glycogen phosphorylase is active in phosphorylated state. Means if you want to activate glycogen phosphorylase, there must be phosphate. So glycogen phosphorylase must be phosphorylated, but phosphate is deficient in the cell. So this glycogen phosphorylase will not be activated. So this will remain inhibited. When this will remain inhibited, this glycogen will not be broken down to maintain blood glucose, fasting hypoglycemia. Fasting hypoglycemia. This glycogen will accumulate in liver, and there would be hepatomegaly. There would be hepatomegaly. So in this, you may get confused. Sometimes clinical scenario is asked and they confuse you with glycogen storage disease. You know, liver glycogen storage disease, we have discussed in previous class, liver glycogen storage disease. There is hypoglycemia, fasting hypoglycemia, and hepatomegaly. So how you will differentiate if clinical question is asked or clinical scenario is asked? Then in classical galactosemia, this is classical galactosemia, means this enzyme is deficient. This enzyme is deficient in classical galactosemia. There would be Benedict test positive because this galactose 1 phosphate will accumulate. This galactose will accumulate. This galactose will be filtered and some amount will be reabsorbed. And yes, rest is some amount will come in urine. Benedict test positive. But in von Gilkey's disease, liver glycogen storage disease, this glucose or reducing sugar will not be present in urine. So it's very simple to differentiate. Now, in galactose 1 phosphate uridyl transferase, I told you the name is classical galactosemia. Point it out. Galactosemia means galactose is present in blood. This galactose will also accumulate. Why? When all the phosphate is depleted, then galactose will not be converted to galactose 1 phosphate. Galactose will be accumulated. Extra galactose will be converted to galactitol. Galactitol will accumulate in lens to produce oil drop cataract. So classical galactosemia, oil drop cataract. In this, you will remember the age of onset of symptom is first 2 weeks of life. And when we start breastfeeding, breast milk is having lactose, lactose is having galactose, and this symptom start after breastfeeding. So this is very, very important point, precipitated or relation with breastfeeding. So many times when clinical scenarios are asked, they will mention you that these symptoms started after starting breastfeeding. Okay. failure to thrive, feeding difficulty, vomiting. These are common symptoms of multiple metabolic disorders. Yes, if septicemia is there, even then, yes, these symptoms would be there. So these are not so specific. Jaundice, hepatomegaly, fasting hypoglycemia, oil drop cataract, intellectual disability. These are suggestive of classical galactosemia. Okay. In this, sometimes you will find liver failure is there. We found that these patients who are having classical galactosemia, they are prone to develop septicemia with E. coli. Point it out. Septicemia with E. coli. Why I'm telling you, they will give clinical scenario in which the symptoms would be suggestive of classical galactosemia, and they will relate with microbiology integration, that they will ask which of the following microorganism is most commonly associated with septicemia in this patient. The answer would be yes, E. coli. Investigation, Benedict test would be positive. As you know, this galactose, extra galactose will be excreted in urine and will give Benedict test positive. Glucose oxidase test, yes, glucose would not be there, so it would be negative. Specific test for galactose is mucic acid test. This is a specific test for galactose, and this will be positive. Okay. Other test, newer test, enzyme studies we can do, genetic mutation test we can do, and what's the treatment? Stop breastfeeding, lactose-free diet, because you know the culprit is galactose. Culprit is galactose. Clear? Now we will discuss clinical scenario. A 3-week-old neonate who began vomiting 2 days after birth, usually within 30 minutes after breastfeeding. So relation with breastfeeding is there, vomiting is there. He has abdominal distension with enlargement of liver, hepatomegaly, jaundice. Consulting doctor did 2 urine dipstick test. One specific for glucose was negative. Definitely urine is not having glucose. It is having galactose. But second test for reducing sugar was positive. I told you all monosaccharides are reducing sugar. Galactose is also reducing sugar. Benedict test will be positive, or test specific for reducing sugar is positive. Yes. What is the diagnosis? Thank you, dear Arpit. Yes. Von Gierke's disease, you can easily rule out. It is ruled out. Yes, von Gierke's disease, hepatomegaly would be there, fasting hypoglycemia would be there, in fact, severe fasting hypoglycemia there, lactic acidosis, hyperuricemia, so many symptoms. I'm not concerned about these symptoms. I will rule out simply saying that in von Gierke's disease, that reducing sugar will not be positive. So it's not the answer. Answer is classical galactosemia. Classical galactosemia. Two option A and C are left. I will discuss these two option, rule out these option after fructose metabolism, and you will appreciate the quality of integration. Okay. Another question I will take deliberately. What is the reason? In few question you will find in place of galactose 1 phosphate uridyl transferase, you may simply find GALT. Short name of galactose 1 phosphate uridyl transferase is GLT. So remember this. A newborn is brought to pediatrician due to lethargy on third day after birth, vomit after forced breastfeeding, bilateral oil drop cataracts. Also noted on eye examination. Based on these clinical finding, which enzyme deficiency? Simple question, oil drop cataract, when you see either galactokinase deficiency, yes, galactokinase is not given, but other than this oil drop cataract, they have given few more symptoms. Point it out. If oil drop cataract is given in the question, and they say only and only symptom is oil drop cataract, then the deficiency is galactokinase. Galactokinase deficiency, only and only cataract. I do remember like this. Kana. Kana means one-eyed man. Only eyes are affected. Okay. Yes. So answer is this. So now we will discuss fructose metabolism and we will try to integrate that galactose and fructose metabolism, why they are different. Okay. So I have discussed till now classical galactosemia due to galactose 1 phosphate urtyl transferase and minor type of galactosemia. If you want to add, this is a rare variant. If UDP galactose 4 epimerase is deficient, this is rare variant of galactosemia, and this is benign. Variable presentation. So sometimes few literature says classical and non-classical. So classical galactosemia, you all know, the remaining two are part of non-classical galactosemia. So no need to get confused by these classifications. You must know the concept. Now we come to, yes, fructose metabolism. Fructose is fruit sugar. You all know fructose is fruit sugar. And fructose is also present in honey. And the sugar we are using in daily life, sucrose, is made up of glucose and fructose. I told you in disaccharide, one unit is usually glucose. The second unit we usually find, yes, sucrose, Shukrawar, Friday. Shukrawar, Friday. The second unit is fructose, sucrose, glucose, and fructose. This is source of fructose. Just to make mnemonic, fructose is fruit sugar. Fruit हिंदी में कहते हैं फल. L for levorotatory. Yes, fructose is strong levorotatory. Yes, if you take fruit, you will be strong levorotatory. And fructose is sweeter than glucose. Yes, this is the reality. Fructose is sweeter. That's the reason that honey is sweeter. Yes, that's why we usually say to our girlfriend, boyfriend, husband, wife, hey, honey. Nobody say glue glue. Say honey. Okay, so you will remember like this. Fructose is a keto sugar. Fructose is present in fruit. Fruit, if you cut, keto, kato, yes. And when you will cut fruit, bee would come, honey bee would come. Aldolase B. One enzyme is aldolase B. So just for the time being, I made this mnemonic that fructose metabolism, yes, the enzyme is aldolase B. In glycolysis, I write here, glycolysis, aldolase A. Aldolase A. But in fructose metabolism, aldolase B. Site of fructose metabolism, liver. Now, if I say that this fructose is converted to fructose 1 phosphate by fructokinase. Fructokinase. Oh, you all know all kinases are transferase. All kinases require magnesium as cofactor. ATP is used or produced. So in this ATP is used. ATP is converted to ADP. Now, fructose 1 phosphate is converted to glyceraldehyde and DHAP by aldolase B. This is important. Aldolase A, the substrate is fructose 1,6 biphosphate. This is important point. If a question is asked on galactose metabolism in your university exam, then you can point out this, highlight that what are the substrate of aldolase B and aldolase A. Aldolase B, the substrate is fructose 1 phosphate, and you at the same time would mention the substrate for aldolase A is fructose 1,6 biphosphate. This is aldolase A. I will integrate, don't worry. This is glycolysis. Fructose 1,6 biphosphate in glycolysis is converted to glyceraldehyde 3 phosphate and DHAP by aldolase A. So fructose is having 6 carbon, 2 phosphates are there. Glyceraldehyde is having 3 carbon, 1 phosphate is there. DHAP 3 carbon, 1 phosphate. So you can easily understand that fructose 1,6 biphosphate, 2 phosphates are there, 6 carbon atoms are there. So when you will cut 2 molecules having 3 carbon and 1 phosphate can be produced very easily. But in case of fructose metabolism, yes, you have only 1 phosphate. Where to go? This phosphate decided to go with dihydroxyacetone to make dihydroxyacetone phosphate. And glyceraldehyde is produced, not glyceraldehyde 3-phosphate. Glyceraldehyde is produced. Now, if fructokinase is deficient, further metabolism I'm not discussing at this time. First of all, I will use the clinical implementation, then we'll complete the cycle or complete the pathway. It's not cycle. Cycle is Krebs cycle in which, complete circle is produced. It is pathway. Okay. Yes. So fructokinase deficiency lead to essential fructosuria. Essential fructosuria. Point it out. In galactokinase deficiency, I told you that is galactosemia. Galactosemia. Semia means in blood. Fructosuria. Urea means in urine. In urine. Why it is called fructosuria? Because when fructose is not metabolized, it will increase in blood, but it will be freely filtered via glomeruli and it will not be reabsorbed properly. I told you that renal threshold of fructose is low. So this fructose will not be absorbed completely and most of the fructose will be excreted in urine. So in blood, fructose will not increase. When fructose will not increase in blood, it is not going to produce complication. Means these patients are asymptomatic. These patients are asymptomatic. Now you can understand why it is called essential fructosuria. It is essential that fructose should be excreted in urine to keep the patient asymptomatic. Now you can relate very easily. Why it is called essential? Fructosuria means it is essential that fructose should be excreted in urine to keep the patient asymptomatic. Got the point? So this is patient is asymptomatic. But fructose is coming in urine. Fructose is monosaccharide, and all monosaccharides are reducing sugar. So all monosaccharide give Benedict test positive. So this will also give Benedict test positive. Benedict test positive. Clear? Now, second, aldolase B deficiency, that is hereditary fructose intolerance. Intolerance. Yes, in this aldolase B is deficient. When aldolase B is deficient, this fructose 1 phosphate will accumulate. The same concept as was in classical galactosemia. All the phosphate of cell will be sequestered here. Means fructose will take all phosphate. Phosphate would be low, decreased phosphate, inorganic phosphate in the cell. So all symptoms of galactosemia. Yes, why I have taken galactosemia and this hereditary fructose intolerance together. Yes, all symptoms similar to galactosemia, but no cataract. Means phosphate would not be there. When phosphate would not be there, then this glycogen phosphorylase will not be activated. When glycogen phosphorylase will not be activated, glycogen would not be broken down to maintain blood glucose. Yes, and there would be fasting hypoglycemia. Glycogen will not be broken down, so it will accumulate. When it will accumulate, hepatomegaly would be there, and extra fructose will be excreted in urine. Benedict test positive. So how you will differentiate? Clinically, I don't ask you about the lab investigation. How you will differentiate that galactosemia and hereditary fructose intolerance, these two clinically? First thing is age of presentation. Yes, galactosemia, classical galactosemia present and yes, within 2 weeks. Because as you start breastfeeding, galactose will come in diet and will start these symptoms. But fructose comes in diet around 6 months when we start weaning. Yes, typical clinical scenario. The parents would bring the child, Dr. Saab, up to 4 months, 5 months, he was absolutely okay. But his grandparents started giving fruit कि अपने बच्चे को पोते को तगड़ा बनाएंगे हम, powerful बनाएंगे, fructose fruit juice is strong. So that's why they started early or at 6 months. Means typical history that when we started weaning, started fruit juice. Fruit juice is having fructose. These symptoms started. So many times they don't ask much about that cataract. They simply say that what is the age of presentation, and on the basis of age of presentation, you can differentiate between classical galactosemia and hereditary fructose intolerance. Got the point? Investigation. Specific test for fructose is Selivanov test, rapid furfural test. I know in MCQs you can easily solve. S for sugar. Okay. F, 2 time F. F means it is for fructose. Again, furfural F, fructose. So at least in, you know, MCQs, a university exam now, most of the university exam are asking MCQs. Okay, so and MCQs are most scoring part of your university exam because direct question and direct number. Yes. So enzyme studies, now latest we can do enzyme studies and genetic mutation test. Treatment is sucrose free diet or fructose free diet. One point I would like to highlight that this fructose 1 phosphate is direct inhibitor. This is direct inhibitor of glycogen phosphorylase. Although indirect mechanism I have told you, yes, at literature it is written that it is directly inhibiting glycogen phosphorylase. Now I will give you a very good example. What happened? There was a patient. Suppose I take on me. I am having hereditary fructose intolerance. Aldolase B is deficient. I am taking face-to-face class since morning. I am tired. I am aware that I am having aldolase B deficiency. Yes, I should not take fruit juice. But coordinator thought that sir is tired, so much of hard work he is doing. Let us give him quick energy. What I use the word? Quick energy. Why I am saying quick energy? I will justify. He gave me fruit juice. I forgot. I took fruit juice. Class was continuing very nicely because my liver glycogen can contribute blood glucose up to 16 to 18 hours. I started in the morning. In lunchtime, he gave me fruit juice. I can maintain blood glucose up to evening. But as I took fruit juice is having fructose. Fructose will be converted to fructose 1 phosphate. It will inhibit glycogen phosphorylase, and whatever glucose I was contributing, my liver glycogen was contributing, will stop hypoglycemia, fainting, class over. Okay. So actually this question, why I told you in this way, funny way, because this question has been asked 2 times in which they will give after giving fructose, they will twist the language in such a way that you will be confused that after giving something, how hypoglycemia can occur. After giving fructose, there is hypoglycemia in hereditary fructose intolerance because this fructose will be converted to fructose 1 phosphate. It will inhibit glycogen phosphorylase and fasting and hypoglycemia would be precipitated. Now, this glyceraldehyde is converted to glyceraldehyde 3 phosphate, glyceraldehyde 3 phosphate by triose kinase transfer a phosphate group, so phosphate will be attached. DHAP will be converted to glyceraldehyde 3 phosphate by isomerase. So two molecules of glyceraldehyde 3-phosphate will be produced in this fructose metabolism. Now, glyceraldehyde 3-phosphate, glyceraldehyde 3-phosphate will enter the glycolysis. So, yes, you are aware about glycolysis. So this you can draw over here also. Glyceraldehyde is converted to glyceraldehyde 3-phosphate. DHAP is converted to glyceraldehyde 3-phosphate, and ultimately glyceraldehyde 3-phosphate enter this glycolysis at this point. This is important because in glycolysis, the rate limiting enzyme is phosphofructokinase is the rate limiting enzyme. And if you give fructose, this rate limiting, this is the constricting neck, means this glycolysis will determine how much glucose should be utilized for the production of energy at the level of this phosphofructokinase. But in case of fructose, this phosphofructokinase is bypassed and there is no regulation. Immediately it will enter to produce quick energy. That's why I told you it will give quick energy. Yes. So sometimes we say you are taking fruit juice, and in fruit juice, please be aware they mix sugar. Yes, that is cane sugar. That is having sucrose. Sucrose is having glucose and fructose. So much of fructose you are taking, and that extra fructose. Yes, we have discussed in integration. In integration, extra glucose is converted to fat. Extra glucose is converted to fat. So if you take fructose, if you take in fruits as such pulp, then it is not so harmful or not harmful in fact. Okay, because the absorption would be regulated. But in case if you are taking that sugar, cane sugar, which we are using, and that's why we are saying that it is not good for health. We are getting weight by this sugar. What is the reason? Because this sugar is having fructose. This fructose is bypassing this phosphotokinase, and ultimately pyruvate is produced. This pyruvate enter the mitochondria, produce acetyl coenzyme. Sorry, to be a little bit fast. Yes, acetyl coenzyme come out of the mitochondria and take part in fatty acid synthesis. So you know that whatever carbohydrate we take, extra carbohydrate is converted to fat. Let me tell you here, not related to the topic, but whatever carbohydrate we take, 50%, around 50% is used for energy production, and around 50% is stored 10% around approximately glycogen, and 40% around triacyl glycerol. So if you are taking more amount of carbohydrate, extra carbohydrate is converted to fat, means energy requirement is fixed. My energy requirement is fixed. If I am teaching for 3-4 hours and whatever I'm doing, my energy requirement of day is fixed. My glycogen storage is fixed. If I take Lay's, हल्दीराम की चिप्स, यस, इन द ब्रेक, तो ठूस लिया, कार्बोहाइड्रेट खूब खाया, और कार्बोहाइड्रेट से क्या बना दिया तुमने? फैट. Yes, triacyl glycerol. That's why we started saying Atkins diet. Atkins diet is low calorie plus low carbohydrate diet. Carbohydrate should be low. So that's the reason that this fructose, if you take, it may be having adverse effect of being converted to directly fat without regulation at the phosphokinase level. Now, I exclude these two options. I exclude these two options. Yes, in this question, I told you I will exclude in the later part. Essential fructosuria can't be the answer because patient is asymptomatic. In this symptom is there. So yes, 3-week old neonate who began vomiting, abdominal distension. I told you the answer was classical galactosemia. In this, yes, essential fructosuria, patient is asymptomatic. Yes, so it can't be answer. Hereditary fructose intolerance present, age of presentation is when we start weaning. Yes, not in 3 weeks of 3 weeks old neonate. So you can easily exclude these options. Now, you will tell me the answer of this question. Routine examination of urine of an asymptomatic patient showed a positive reaction with Benedict test. Yes, Benedict test is positive, but a negative reaction with glucose oxidase test, GOD. Which one of the following sugar is least likely to be present? Yes, least likely. Please do comment. Arpit, Atha Saur. Yes, sucrose is a non-reducing sugar. Non-reducing sugar will never give Benedict test positive. So least likely is sucrose. You all know the mnemonic of non-reducing sugar. Mnemonic is no rest. No rest. Non-reducing. S for sucrose. T for trehalose. Trehalose. So this is really difficult question. They have not asked about these, metabolic disorder. They are asking about, yes, Benedict test, which is non-reducing sugar. Non-reducing sugar is sucrose. It will never give. Yes, they ask least likely to be present. So sucrose. But in the same question, if I change least in place of least, most likely. Yes, patient is asymptomatic, Benedict test positive. Most likely, the patient is having essential fructosuria. The answer would be changed. Essential fructosuria means most likely the answer would be yes, fructose. The answer would change to fructose. The purpose to discuss this type of question is that whenever you attempt any question, okay, it's not as I found that many students commented and gave me feedback that sir, in our university MCQs are being asked, so that's why I'm taking care of MCQs also. Okay, so uh, they will give change only one word and the answer would be changed. So keep in mind. Okay. Now, sorbitol pathway. Sorbitol. You know glucose. Glucose is having formula C6H12O6 and at carbon number 1 there is aldehyde. And we found that there is an enzyme aldose reductase. Aldose reductase, whenever reduction is required, you use NADPH is converted to NADP. And this glucose is converted to sorbitol. So I have drawn this structure here only. This is glucose. This is glucose. If I join two hydrogen at this point, H, H, this is OH, 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 OH. Yes. Okay, dear. One doubt. Yes, genuine doubt. In this question, patient is asymptomatic and least likely. Yes. So Benedict test is positive. So galactosemia, Benedict test would be positive. So there are chances that galactose is there. Got the point? So understood? Actually, this question is not based on the metabolic disorder. It's based on the reducing and non-reducing property. Yes. Yes, Glucose is converted to sorbitol by aldose reductase. NADPH is used. Sorbitol, now this is sorbitol. Look at the screen. This is sorbitol. Sorbitol. Previously, glucose was having 5 OH. OH means alcohol. Alcohol means ol. Now it is having 6 OH. 6 ol. Sare ol sorbitol. Ol sorbitol. Yes, sorbitol. Sare ol sorbitol. That's why this sorbitol pathway is also called polyol pathway. Now, sorbitol is converted to fructose by sorbitol dehydrogenase. Sorbitol dehydrogenase. In this, NAD is converted to NADH. Clear? Yes. NAD is converted to NADH. We found that in lens, nerves, kidney, this sorbitol dehydrogenase activity is less, and in diabetes, blood glucose is high. Blood glucose is high. So more and more glucose enter this sorbitol pathway, and this sorbitol increases. When this sorbitol increases in length, this cause snowflake cataract. Snowflake cataract. Okay. Nerves, diabetic neuropathy, diabetic nephropathy, diabetic neuropathy. We found, yes, there is a relation that most of the complications of diabetes are contributed by, not is the cause, but contributed by this sorbitol. And the culprit is aldose reductase. This is the reason to decrease the complication of diabetes. We developed inhibitor of aldose reductase. Aldose reductase inhibitors. Those are alrestatin. Name itself tell you. Aldose. RE for reductase. Statin. Aldose reductase को static बना देगा. EP alrestat. Alrestat. So again ALRE. Aldose reductase inhibitor. Okay. So this is about sorbitol pathway. This pathway normally occur in seminal vesicle. As you know, seminal fluid is rich in fructose, and this fructose come from sorbitol pathway, and sperm require fructose for their motility. So this is about sorbitol pathway, fructose metabolism, and galactose metabolism. Hope you have enjoyed the session. Thank you for patience listening. Remain connected. We will discuss more and more interesting topic in these sessions. Thank you.